syndrome. And then with our patients that are suffering from medial tibial stress syndrome, they commonly have what motion of their talus? Are we talking about internal rotation and inversion, internal rotation and eversion, external rotation and inversion, or external rotation and eversion? Because when they were going through that study that Yuxel performed, again, remember they were stating that these patients were sitting with their talus actually out of alignment within their mortise. So they were sitting with a talus that was externally rotated and everted, which again, that kind of plays in line with that inversion-eversion balance. If our inverters are weak and our evers are tight, we're going to be stuck with that talus and eversion to begin with. And then same thing with external and internal rotation of the foot. That imbalance is overcoming one another, and we're being stuck with that talus out of place and out of position. Kind of gave this one away a little bit, but patients suffering from medial tibial stress syndrome often have imbalance of which two motions? So hip flexion and extension, decreased hip flexion, yes, that's a predisposing factor, but we really didn't say anything about extension. Knee flexion and extension, we didn't talk about that one either. Dorsiflexion and plantar flexion, surprisingly, that one didn't really come up in the research, but inversion-eversion was the imbalance that was the most consistent with those medial tibial stress syndrome patients. And then true or false, therapeutic exercise programs have been shown to assist in the treatment and prevention of the medial tibial stress syndrome, but these programs have not been well documented in literature. And that takes us back to that one study we talked about where they performed their short-term therapeutic exercise plan, but ultimately they decided they were going to keep some secrets to themselves apparently within their research because they were vague about it. And so right now we still need more documented evidence or documented methods for these therapeutic exercise programs as these studies are coming out. And then lastly, going back to that anecdotal portion of this, which of the following treatments have been shown to assist in treating the medial tibial stress syndrome, at least within kind of the little brief case that I discussed with you all? So we talked about cupping therapy applied to that medial soleus since it has that attachment site on the distal 2/3 of the tibia. NSAIDs, well, we said that only thing we really talked about with inflammation was that the periosteum isn't inflamed. And then leukotape tabs along the posterior medial tibia to provide that compression that we talked about. And as we went through those slides, we actually ended up talking about both A and C as methods that we used anecdotally to decrease our return to run time and return to activity time for our patient population. So again, most of these are going to be overlap citations if you decide that you want to go through this journey yourselves again. But there is a growing wealth of information that's going to be out there on medial tibial stress syndrome. So at this time, do we have any questions?
Just a couple of questions.
Okay.
One of them is, what would you suggest to our cross-country track coaches to reduce medial? Okay, sorry. And can calcium supplementation be helped by proper amounts of vitamin D and magnesium to aid in absorption of calcium?
As far as that one goes, I'll go ahead and answer the calcium and vitamin D one first. That's an interesting area because a lot of recent information, and it was actually a few years back at this conference where Dr. Jack Ransom, who was working with the Spurs at the time, mentioned that using vitamin D3, they were having good results in terms of reducing musculoskeletal injuries. So that's kind of why within that slide we talked about we need to try to decrease the incident, or we need to do more research to try to decrease the incidence of medial tibial stress syndrome with nutrition supplementation, because using magnesium or vitamin D3 to kind of help out with that calcium, that might be the missing piece that they left out in that previous study. So there's absolutely some growing evidence that vitamin D3 especially is going to be something that's going to be good for your patient population and something that would definitely be worth exploring further. And then what was the first part of that first question? Or? Oh, that was that one. Okay. So, all right.